Kristine is now going to delve deeper into some of these ideas.
Absolutely. So I think this is a great setup for, I'd like to bring a little bit of the public health perspective to our discussion. And I also would like to sort of come back to some of the themes that have been brought up, in particular this question of neuroplasticity. So I think this is really a tremendous message of hope for brain science. We know in the last decade or two that the brain is capable of changing. It's capable of creating new neurons, particularly in the hippocampus. So what does this mean? I mean, it's not what we learned in medical school, which is that you have all your neurons, and every time you hit your head or have a glass of wine, you're going to, destroy some of them. It's much more complicated, but think of the therapeutic potential. It's so exciting to me. And it also brings together, I think, a lot of dichotomies we have in medicine of, if you're doing psychotherapy versus doing medications. Well, guess what, guys? They're changing the brain probably in the same way. It's a rewiring of the brain. It's strengthening certain networks, changing networks, having new neurons grow. This is terribly exciting, and I think the whole field of clinical neuroscience is now about to be able to embrace this. So I want to start with a message of hope, because I think this will interdigitate with cognitive aging, and a lot of the therapies that are now being investigated, brain stimulation, we heard about physical activity, these all probably have mechanisms based in neuroplasticity. I want to also come back to this continuum issue that I think both Eric and Tom brought up. The continuum idea, I think, is so important for us because, again, people just don't all of a sudden wake up and have dementia. That happens, but quite rarely. What this is a decade, probably decades process of the different neurodegenerative pathways building up in the brain. So there's probably a decade or two of a preclinical window, which really offers us a wonderful opportunity to intervene, to understand the biology, either in conjunction with other pathways or in its own pathway. So I think this is terrific. And now we have good biomarkers to look at some of these. So whether it's the PET ligands of amyloid or tau, or some of the CSF markers, we really can get a better sense of that preclinical window and understand where we can intervene, and also how do we parse out cognitive aging per se. You heard a little bit of that this morning. Is it possible to parse out all of that neurodegeneration, and what are you left with? I frankly am not sure it matters so much, but it is interesting that I think we can get more at that biology. So the third thing I want to talk about, and again, this is a theme I think of our discussion, the brain is terribly complex. And why haven't we had any good drugs for the last 2 decades? Or why haven't we had any new drugs in the last 2 decades for Alzheimer's disease? Because the brain is complex, and we're probably going about it the wrong way. We've been thinking just of one pathway. Often the preclinical work wasn't maybe as strong, and I don't think we're embracing the complexity. Even these wonderful trials that you mentioned, Diane and A4 and API, they are wonderful proof of concept, I think, because you're taking very rare individuals, people who are young, who have an autosomal dominant gene. They're going to get Alzheimer's disease. Let's look at the preclinical phase. Let's give them an amyloid drug, or let's take a brain full of amyloid by PET. Wonderful, I think, in terms of a model for whether these amyloid interventions work. The problem, as you beautifully mentioned, that's not your average person. Your average 80, 70, 80, 90-year-old does not have one pathology. They don't have a rare autosomal dominant gene. So we need to get much better, I think, at looking at the whole person, different pathologies, certainly vascular as well. And to that, I think we really can't forget the lifestyle. We've heard a little bit today about, is it more the environment? Is it health disparities? Is it the biology? Well, of course it's both. And I think in no place is it more true than in the brain. The brain is so complex, and by the time we get to be in our 80s, it's a lifelong history. Lifelong exposure to cardiovascular disease, to physical activity or lack of activity, education, quality of education, depression, certain medications. Sleep is now becoming a very important strategy to probably intervene. Certainly traumatic brain injury. These are some of the big lifestyle factors, I think, that we have excellent evidence that affect cognitive aging, they increase risk of dementia. We need to really get better at trying to intervene on these. And again, not just maybe on a one path. You know, we need to be thinking, these tend to cluster together. In fact, we've done some work where we think that if you account for all of these modifiable risks, you probably could account for about 30% of the variance in Alzheimer's and other dementias. So it's not everything, but it really offers us hope. And I think if we could do a little, just change behavior a little bit, we could have a big effect. So if we got everybody to exercise a little bit more or stop smoking, not even stop, but reduce, we could have a big effect. And as Eric mentioned, it's really fascinating, but a little bit off message and something that we haven't heard a lot about, and that is there are now about 7 studies that have shown within their study, they look at the prevalence of dementia, say in the 1990s or 2000, and then 10 years, 20 years later, they repeat the exact same methods, and they have found, sort of remarkably, that the prevalence in these studies, that the dementia actually is plateauing or being reduced. Fascinating. It doesn't go against the message that we are in a major epidemic because of the demographic shifts, because we're living longer, but I do think it offers some hope. We need to get a little bit more granular. What happened during that decade or two to cause that change? I think a lot of it's cardiovascular disease care. Statins were introduced. There's some secular changes, secular trends in education. When you think about, particularly in post-World War Europe, the quality of education changed. So I think, actually, and I'm going to end with this, I think it offers us tremendous hope, because maybe we can do something about this, both in terms of the more complicated biology pathways, but also really at some basic public health avenues. And finally, there was a trial that was just published in Lancet. It was a Finnish study where they actually did this multi-domain intervention. They did cardiovascular control, cognitive stimulation, physical activity, and lo and behold, they found that the rate of change in cognition was improved in the intervention group. And they're now going to look at whether this affects dementia. So I think that there's a lot of hope, but we need to not be working in silos. We need to be working across systems and really across modalities of intervention, both medications targeted at the pathways, but also environment and lifestyle. And I think it's going to be like cardiovascular disease. I think dementia and Alzheimer's will turn out to be a combination where we give multiple drugs and multiple lifestyle changes.
Thanks, Kristine. Now,